Very good evening to all friends. So this is the demo session. This is just meant to provide you idea about our program because most of you have joined through our social media ad from the Instagram, Facebook, or YouTube. So before joining any online program, every doctor have lot of doubts about the integrity of the program, whether this program will be useful for me or not, or because of hectic schedule, lot of people think that no, we are not be able to get fined. So let me tell you that this program is designed in such a way and only for the most busy doctors. I will be explaining everything in detail and how we conduct the session. And even if you are most busy doctor, even then you can easily catch up. Everything will be available on a website. This will be a two interactive program. It's not like some kind of other online program where you go and purchase and they will throw you the video tutorial course material. Because CT scan cannot be learned without a two-way interaction and your personal involvement. Okay, so in this two-way interaction, we are going to give you clips where you will scroll up and down and we'll check the pathologies and lot of things are there. So this program will make you expert in a manner like the radiologists learn in with the clips. When some patient come, they scroll down with their senior. Initially, they learn how to learn, not from CT films. Most of if there is a radiologist how to join our program, so you know better because you never study from the film. Although there is theoretical stuff, you can go through that slide that how the aortic aneurysm or some other pneumothorax, hydropneumothorax look like. You can go through that, but when you go to the check the city clip, you need a practical. Okay, so it's like a physics numerical. Just by knowing the formula, you cannot solve the equation. You need a practice like mathematics. So this program is a two-way interactive program, and let me share my screen with you so that you can get an idea about this. Okay. So friends, we are going to start this program in the September, and this will be a two interactive program, and I'm sharing the PDF with you. And without delaying, I would like to tell you what are the topics we are going to cover today. And although we cannot teach all the radiology in just 1 2 hour this Zoom webinar, but at least we will give a superficial touch about everything and about model of teaching and what are platforms. So what you're going to learn today, basics about CT scanner machine, its parts, how it's work. Very basic, in short. Various planes, you know, axial, sagittal, and coronal, various planes. And the windows, what are the soft tissue window, medicinal window, what is the HRCT or bone window, and their significance of you. And site determination and introduction to our online CT learning program, because you must know how we conduct this program and how we will get flexible according to your busy schedule, and you need a flexibility of timing and not a kind of burden or time bounding to Zoom session like that. What will happen? A lot of doubts are there. What will happen if I miss this Zoom session or like that? So let me describe you the complete pattern about our program. So there should be no doubt. And some time, if time percent, we will be covering some mediastinal pathology. Also, we will go through some cross-section anatomy also. Not we are not going to we are not even if some beginner has joined, so he will not be able to learn immediately. But whenever he or she will join our program, everything is available on the website, and we will practice on that also because without cross-section or you cannot learn CT scan. So apart from that, in lung window HRCT, we will be covering the various patterns like ground glass opacity, crazy paving, mosaic pattern, pre-embed opacity, and interlobular thickening, ground glass opacity, and honeycombing, lot of things. And these are very helpful in making differential or different issues that you will realize later. And apart from that, COVID radiology, which is the I don't know who is teaching it or online it, COVID radiology, but we are going to teach you complete COVID radiology for our classification and CT severity scoring also. And apart from this, we are going to teach you CT head also, emergency part, and not mentioned in this is CT emergency part like head injuries, common stroke, hemorrhagic, ischemic stroke, both, and various kind of normal pathology, the hydrocephalus, cerebral edema, or in like MC impact in non-ischemic stroke, but MC is covered, AC is covered, which arteries involved, like that, and other common pathology like neurocystic tuberculosis, some kind of as well or space occupying lesions. Those are very common. So most commonly we will cover the CT chest part, mediastinal HCT and part and radiology and emergency part in the CT. Right. So without delaying, let us start. So little bit about definition of CT or computed axial tomography. Can anybody tell me one thing that why we called it as computed axial tomography? Why we use word only axial? Although other sections are also available like sagittal and coronal. Why don't we call it as computed sagittal tomography like that? Anybody? You can write down. Okay. So let me make you this clear. So first of all, just learn the meaning of tomos, and tomos means to cutting you, and graphia means to study. And what happened? Uh, this is CT scanner gantry, and first of all, the image is constructed in an axial view. So that's why we called it as computed axial tomography. And later, the image is sent to central processing unit, and various other plane are reconstructed. So like this, all information is sent to the central processing unit, then it will reconstruct the various windows. I will be just discussing about that and various planes. So before that, let me tell you about little bit about our program. So our program is not like some kind of time binding program. Even if you are very busy doctor, because undergraduate will not come to learn the CT because only those people like senior practitioner or who are doing MD and in medicine or who are doing who are just joined the uh, this radiology branch, MD radiology or anything, and also GR1, GR2, even senior radiologists also joined our program in the past. We were again not in touch of the city, so they have also appreciated our program. So any kind of member can join. Even if you don't know how to hold the city film, you will become expert at the end of the program. And you can check video feedback, lot of feedbacks are there. You can go through that. I will provide you the link. Okay. So let us start. So our platforms are WhatsApp. Why we are using WhatsApp here? WhatsApp, Zoom, and our website. Three platforms. So why we are using WhatsApp? WhatsApp is a every doctor, whether he is a very hectic schedule or that, cannot escape the message coming going into WhatsApp because it is related to his hospital staff and some case. So that's why we use this platform to send the notification, push the notification immediately, so that you should not miss anything. Because if we conduct program on some application, you may miss for 5 to 6 days, and that will be no use. It's a two-way interactive program, not a self-study program. So you will get daily notification and about what will be happening today or day after tomorrow. Okay, so we will be announcing that please go through chapter 1 and 2. We are going to conduct a practice session on WhatsApp. So we will be conducting what is practice session on the WhatsApp. We are going to give you clips. We'll ask you what is the pathology stored up and down. Similarly, in the manner as radiologists learn. They don't learn from the films or because it's like a physics numerical. Until unless you practice on your own, things will not work. Just by learning the formula, it's like a practice. So you need to be practiced and that too in a under guidance of a tutor and there will be WhatsApp sessions at a particular timing, and at that particular timing, I'm going to post the clip and will ask to mark the pathology, take the screenshot, mark the pathology. So it will be like a virtual classroom. And we are conducting this program since last 7 years, and it's great success. We have a lot of video feedback. If somebody wants to check, you can visit my YouTube. I will send the link. And Zoom, we will be conducting the weekly Zoom revision session, and maybe one or two according to the demand. And our website immediately as soon as you join, we'll give you access to our website tutorials. There are many tutorials, 40 tutorials for and on. So you can go through that tutorial and you can prepare in the start learning. As soon as you register, you will immediately get to the access to the website. And when the two interactive program starts in this in the September, and then you will not be feel it very difficult of in managing your timing. You may have a hectic schedule. So in advance, if you cover some topic, then later it will be very helpful to you. So it is highly advised. A lot of members already joined our program and started learning. And so members who are watching this video, so they can register immediately, get the website access, and start learning before we conduct the two-way interactive program. I will be telling you how we conduct two-way interactive. So first of all, let me show you my website. Let me share. Friends, you will get immediate access to our website. You can go through this video tutorial. There are 43 lessons and sub-lessons, sub-topics. So you will get this kind of demonstration on the CT. Like you can see, this is the case of trauma. There is a pneumothorax and subcutaneous emphysema. So let me stop this and come back to the PowerPoint presentation. So let us have an idea about this, how a CT scanner works. So this is a ring-like shape structure. This is a gantry. It rotates around the patient, and there is an X-ray meter at one end, and just opposite to it is receiver. And this gantry rotated very high speed, and X-ray meter send the X-rays and it receives, and it rotates, and then all the data is sent to the central processing unit, computerized system. So it will reconstruct the image. So this is the how it can ever. Apart from this, you can see here there is a patient couch. This is gantry. And apart from this, there is a view console where the technician is sitting or radiologist sits. Okay. And now, without delaying, let us discuss about what are the windows. Very important thing, especially for the beginners. So there are three types of window: soft tissue window or mediastinal window, lung window, or HRCT, and bone window. So most important, these two are most important, as you can see here. So this is the soft tissue window. In this window, you cannot see the lungs. You can see dark picture. You cannot see the lungs. This is especially to visualize the mediastinal structure, like heart, aorta, pulmonary trunk, superior vena cava, chambers of heart, ascending, descending aorta, zygote veins, superior vena cava, all these things. Whether there is a pathology in the mediastinal or there is a pneumopericardium or like that. So this is the for the we can also see the pleural effusion in this window, but not other pathologies. Okay, so this is the lung window or HRCT. HRCT is higher resolution CT scan. It cuts the body into very thin slice. So this is preferred to check the any lung disease, lung parenchymal disease, very so various patterns, various disease, cavity, like that, means everything. This is the bone window specially used to visualize the bones and other important pathology of the bones, like most of the tumor is there or like that. So this was all about windows. Windows are nothing, just a technical setting. You will ask the technician, or you can yourself switch over to one window to another window, and it will get immediately uploaded, and you can check according to the need. So next come the planes or the views. So just look at here. This is the CT head. This is the section, and here we are. This is just to demonstrate the planes or views. Okay. So just suppose if I cut my body like this in slices, like you can cut the banana in the slices. What you will get a round figure like X here, X here. Okay. And suppose if I cut my body into right and anterior and posterior part like this, so you will get this coronal plane. Okay, coronal plane. Sagittal, simply cut my body into right and the left part for studying. You will get this sagittal thing. Very easy to understand. So no need of me. So uh, if you have access to the ECT scan machine, you can visit and immediately check the various views, because some pathology are visible, good visible in the axial plane, other in the coronal, or some in the sagittal section. So here you can see we are moving here. Okay, so we can see here. So also you can see this cursor is moving up and down. So whenever you can go through axial section and find something is abnormal. So just to cross check, we can check in the coronal section at the same section and sagittal. So these are the significance of the windows, various windows, and not only window, but various planes in various planes for different directions. How we analyze. So some pathology can be visible in the axial, other we have to check the coronal window. So like that. So next thing is side determination. Side determination where just imagine the patient is lying in front of you, facing his feet towards you. Okay. So his left will be your right. So this will be left. He's lying now. Left, right. Very easy. And vice versa. Right. Very easy. So friends, next comes cross-section study. So we are going to teach you cross-section and anatomy in a comparative manner, like axial section, and sorry, cadaveric section, because all of you might have read anatomy during your first year or maybe during PG preparation. So you might have some memory in subconscious mind that we are going to give you comparatively slides and how you have seen in the cadaveric section and how it's in a CT scan and what structure are more prominent. So like this is the medicinal window, this is HRCT. So like this. So like this. Let me show you this plain cadaveric section. So here you can see the CT is the lung, left and right lung. Here you can see this arc of aorta was there. This is arch of aorta, and here you can see left brachiocephalic merging to right brachiocephalic vein. This is trachea. So we will be discussing in more detail while covering in the main program. Right now, it's not possible to explain each and every second, but I will try to demonstrate with an CT clip. So please go through this. So here we are going from top to bottom. We will start from the root of the neck. So just no need to click. I will be going very fast, and this is for demonstration purpose. So let us move fast. So here you can see from here we are going to start. So here you can see this structure. This is left brachiocephalic vein, and this is the right brachiocephalic vein. So left brachiocephalic vein, as we scroll down, it will move towards the right brachiocephalic vein and will get merged to form the superior vena cava. I will show in the some other slide. And these three arteries are spiraling around the trachea. This is the trachea. This is the vertebral body. So you can just this is the posterior part. So this vertebral body. This is the cartilaginous shape structure. This is the trachea. And inside is air. Air is hypotenuse, so dark. Just posterior to it is esophagus. Okay, so let us proceed, and you can see here the three main branches arising from the aorta. Now look, so these three branches spiraling, these are going to merge into the arch of the aorta. And this left brachial swelling is coming closer to the right brachial swelling to form the superior vena cava. So now these three, we are going from top to bottom now. So the complete arch of aorta is formed. This is superior vena cava. This is trachea. This is vertebral body posterior side, and like this. So as we scroll down further, what will happen? This arch of aorta will be no more visible, and there will be ascending aorta and descending aorta. Okay, this superior vena cava, this is trachea. So friend, this comes with learning and practice. I will be giving you a lot of slides for practicing. So friend, here you can see a new structure emerging. This is the pulmonary trunk. This one. So this will give it left and right pulmonary artery. This is the pulmonary trunk. This is the ascending aorta, descending aorta, and this one is the superior vena cava. And here you can see as we move lower down, trachea is widening. And in the lower section, it will get bifurcated into left and the right main bronchus. As we move down, we will be entering in the chamber of the heart. So now we are going just entering inside the chambers of the heart. If we moving slow a little bit. So here, one important part I would like to tell you is the left atrium, posterior mode side. So it's appearing over here, and this part in lower section you can see this is the right ventricle. Right ventricle forms the most of the anterior part of the heart, and this you can see this is the part of the right atrium, and this is superior vena. Superior vena will be draining to right atrium, and in lower further section, right atrium will be available, and superior vena cava will disappear. And this is descending aorta, and this is ascending aorta. Okay, let us trace further. Now, as we so now you can see most of the part is formed by right ventricle, anterior part, and this is the right atrium, and this is the left atrium, and descending aorta. And here you can see the ascending aorta part of ascending aorta. So it's will drain into infundibulum of the left ventricle. Let me show. So we have entered the abdomen. Actually, I will show demonstrate this with another case. So you can see I will be demonstrating with some other case. Okay. Now we'll be teaching you like this. I have told you like this diagrammatically. This is a cadaveric section, and this is A and B. Right. I have told you previously left and right brachial just merge to form the superior vena cava over here. So here you can see in cadaveric section also number one is left brachiocephalic vein, number two is right brachiocephalic vein, and you can see number six is trachea. And these structure spiraling around the trachea are the branches of the arch of aorta. You can see here. Okay. So right now we are at this level. So we cannot see the arch of aorta. We can see its branches. One, two, three, its branches. So respectively, these are the right brachiocephalic artery, left common carotid artery, and the left subclavian artery, like this. So we are going to teach in a 3D this manner with the help of the picture so that for better understanding. Only then you will be able to like this arch of aorta. This is the right superior vein form is forming this remnant part of that brachiocephalic vein, trachea, fourth, fifth is esophagus, and this arch of aorta. And similarly, we will show that this section is taken at this level. And in the CT scan, it will look like this arch of aorta, superior vena cava, fourth trachea, fifth esophagus, vertebral body. Very fast, I have to go for this. Now, next session we will take from the thoracic vein T45, and here an important structure will going to merge is azygous vein. So this is the number 4 is azygous vein, and it will drain into the superior vena cava. So number 1 is ascending aorta, number 2 is descending aorta. This is non-contrast study, so that's the structure are looking rich. So this fifth is trachea, sixth is esophagus. So I have to go very fast. Sorry. So after teaching in our main program, after teaching you about this all pathology, we will be discussing about the we'll be conducting a what's the practice session, and we are going to give you these kind of slides, and you have to tell the what are the structure mentioned. Like this, we are going to give you a lot of slides for the practice, and we'll also cover the coronal study. And coronal study, we are going to move from the posterior to anterior to posterior side. So as we move moving from anterior to posterior side of the chest wall, we can see first this is the first section. Here you can see costal cartilage, not ribs. Now it is hypodense section. Whenever sternum, this is sternum is here, the bone look hyperdense. So here you can. So just as we enter the test, you will see this section. So since this slide is very this video clip is very fast, so you are not able to edit. So let us proceed further. So this is the coronal plane. So let us move. Let us play this clip. So it's very fast click. So as you can see, we have just moving from anterior to posterior, and we have entered the thoracic cavity. You can see at the periphery, these are the ribs, and we have entered the thoracic cavity. We can see the shadow. This is the cardiac shadow. This is the liver. These are the lungs because this soft tissue window, so lungs are not visible here clearly. So as we move more posterior, and we can see here this arch of aorta is arising from the left ventricle here, and we can see just this arch, this ascending aorta will form arch of aorta, and always remember below the arch of aorta is the pulmonary tunnel. So this is very important. On right side there is a liver. Let us trace further. So as we trace further, we can see some more structure. Right, this superior vena cava. Here you can see this is superior vena cava trachea, and this is the aorta. This superior vena cava will bring into the right atrium. Okay, so you can see. So let us proceed. This is the trachea, and at this section we are a little bit posterior part, and so here you can see left atrium is appeared. This one, this on this hypertension, and this is again arch of aorta. Below that is the pulmonary trunk, and this left atrium is receiving its branch from both pulmonary artery, left and right pulmonary arteries. So as we can see here, trachea is bifurcating as we move posterior part. So this is the ascending aorta, pulmonary trunk again, liver, the fundal shadow here on the left side, and as we move more posterior, we can see the this ascending aorta here. So let us uh, So I have got just taken the slides from the moving clip and mark just to make things correct understanding for you because clip is moving very fast. This is one is left ventricle and this is fifth is ascending aorta and this is only arch of aorta and just below arch of aorta is both pulmonary trunk and number two is TDA vein giving into the right atrium and let us some other structures are also there. So here you can see trachea got bifurcated. This is the arch of aorta, and this is again pulmonary tract number four. So as we move further, this one important section. This is the arch of aorta, and just posterior to it, number four, hypodensity gray structure in esophagus. So here, members, you can see a little bit constriction. Can anybody tell me, is it some kind of pathology or something else? Yes, you can type, please. Okay, let me tell you. Most of the people do a mistake. They call it as narrowing of iota or coarctation of iota, but it's not that like that. It's due to normal posterior curvature of the iota, and we can appreciate in the sagittal section. As ascending aorta is arch of aorta, and as it moves, it takes curvature towards the posterior side. So we have taken previous section from this blue line. Look at the blue line. So this is the curvature, posterior curvature. So here it will look deficient. So here it is looking deficient because posteriorly we have taken the section anterior. Right? So that's the thing. So these things should be remembered. What are the normal structure, what are the abnormal structure? After teaching you the cross section orthodontry, we are going to conduct the WhatsApp practice session. You might be curious how we will be going to conduct the practice sessions on the WhatsApp. So let me show you a screen recording of the same, just a small. So here you can see I'm posting some slides after teaching, and members are writing their answer in great detail. We are going to teach the cross section anatomy. Also, I will give giving some voice recording explanation. Various members are giving their explanation about various things. So this is in pathologies, various pathology. We ask the member to take screenshot, mark the pathology, what is the abnormality over here. We don't so there will be a lot of workshop like it's like a virtual classroom. You can ask your doubt anytime. If you're not able to attend the WhatsApp session, you can later go on just check the slide or clip. Just first go through yourself, first go through the clip, make your own interpretation, then only check what other members have commented and or what is the final type in the last day in the it would be better if you attend these practice sessions live. Or if not possible, then later on, it's also like that. If you honestly check some tape, interpret it from yourself, what is the finding, then you may also make mistake. Then check other members' comment and go through. So this is will remain same on your WhatsApp. So video will become very difficult because 1 to 2 hour video, if I conduct the session on Zoom, so it will be very difficult because member will not be participate as much fast as in the WhatsApp. You can understand that we are all here. So even I asked one question and didn't got reply. Some I think some chat is also there. Some member have said that yes, yes, very good. Yes, yes. Excel, about Excel session that we previously asked. So this is how we are going to conduct the practice session. So now little bit talk about the pleural effusion. So you know pleural effusion, you all know collection of fluid between the parietal and visceral pleura. Let us discuss how it will look in the axial section. So mild pleural effusion, you can see a gravity dependent crescent shaped shadow, gray shadow. This is the fluid. Beginners would not be able to appreciate well with practice ability. So because patient is lying, the chest becomes gravity dependent. So fluid will get settled on the posterior part of the chest in the mild pleural effusion. So you will see this like this kind of pattern. And it is also seen in the lung window HRCT as you can see here. But in this slide, you will not be able to differentiate between rays due to same attenuation. So this is bilateral pleural effusion. And let me tell you one thing. In X-ray, suppose there is a then you will patient is in a this is the PA view. Patient is standing. So gravity part will be this will be become a gravity part. Okay. So you will see homogeneous occupancy. But in the CT, as I told you, patient is lying. So lying to posterior part of the chest becomes gravity dependent. So fluid will appear over there. Okay, first. But in massive fluid, you can see lot of fluid up to here. And uh, now let me tell you how it will look in a coronal section. Look, this is the coronal section, and you can see we are at the posterior most part of the chest. Same case, but here we can see pleural effusion. Let me show you the clip of the same case to make you better for better understanding. Here you can see as we move, usually everything seems to be normal. So as we approach, and patient is lying under lying, and we are going from anterior to posterior toward the posterior chest wall, and fluid is collected over the posterior chest wall. So here we can see this here, right? It is. So you can start seeing the fluid, grayish fluid, and this is the fluid. This is the how fluid then we look in a coronal vision. So these things you must need to learn as you have learned in the X-ray part that the patient is AP supine, he is lying down. So there is no gravity dependent research and fluid is scattered all over the place. There are a lot of pathologies like this, not very well appreciated. You can see this is a mediastinal window. You can see this is a pleural effusion here. This is and this is the hydropneumothorax because there is a fluid level. I will demonstrate better in the lung window. Same case. In the lung window, you can see here on right side, lung is visible, but here no lung is visible. So there is air above, below is fluid. So this form a fluid level. So we call it as hydropneumothorax. Left side hydropneumothorax, on right side there is a pleural effusion. Same case and fluid. Apart from this, let us discuss about loculated fluorescence. Sometimes what happens, the fluid could be a inflammatory infection, you get tuberculosis there, or some infected fluid which they start collecting, and it is a thick fluid. Sometimes it could be a blood if it got clotted. So it is thick, so it is not gravity dependent. So it gets loculated or localized for the part. So you can see these kind of things and split pleural kind. You can see this not very and here also you can see we're not going in the much detail, but still in X-ray you might have seen these kind of appearance in the same case, procurative pleural effusion. So this is standing but not gravity dependent. So hydropneumothorax, as you can see, this is soft tissue window. Still we can appreciate fluid in the soft tissue window, not the lung. So you can see fluid there. Above that is air, hydropneumothorax. Although these both parts looking same because no lung is visible. So better it would be appreciated in a lung window. So here you can see same case. Fluid is over here, air is here. So you can see fluid here. But this is the lung. This lung that collapsed. This is the lung. Okay, this is the mediastinal and everything. So right side you can appreciate hydropneumothorax and collapsed lung. Similarly, pneumothorax, here inside the pleural cavity. So here you can see this is air. So pneumothorax, collection of air between parietal and visceral pleura. You know, pneumothorax. No need to explain the pathology or already studied and no everything. So this is the lung. So air got accumulated and so collapsed the lung. You can see here on left side everything is normal. Okay. So let us proceed further. So let me share one road roadside accident. So you might be thinking what kind of these happen. Actually, this is subcutaneous lymphoma, and in chest injury or trauma or roadside accident, you may find multiple findings like there could be multiple leg fracture, hydroneumothorax, subcutaneous emphysema. So this is subcutaneous emphysema, collection of hair beneath the skin of soft tissue. So it gives this kind of appearance, and in the X-ray, it will give this kind of appearance. We call it the Jinkuga leaf appearance. You can see here in the X-ray. So don't miss it. So let us talk about a little bit about this. Trauma case is very important, and all of you must know this. So this is the subcutaneous emphysema, as I already told. So let us play the clip again and see what are the other findings over here. So as you can see here, so you here you can see clearly this hypotensive structure, dark here. This lung got collapsed and left is okay. It is subcutaneous emphysema. You may find a lot of other findings also if you go very uh, keen observation if you will check. Okay, so this was little bit about mediastinal pathology. Like let me tell you one more pathology: pericardial occlusion, collection of fluid between the parietal and visceral flora. Oh, sorry, the pericardium. So this is the pericardial cavity. Normally, thickness of pericardium is 2 millimeter, but more than 4 millimeter due to inflammation, collection of little bit fluid, it start becoming prominent. So if you see the heart, this is the heart, cardiac shadow. You see these kind of basically grayish, and you must think about the pericardial occlusion pericardial case. So this is the mild and uh, in other section, you can see the massive pleural, the pericardial effusion. You can see gray shadows. This is the heart. It could be new for the beginner, but later when studying in a systematic manner, in a long study, then you will be able to appreciate. Let me tell you one more important thing. Let me show you a dynamic rate of the same pericardial, massive pericardial effusion. So here you can see this is the heart and this is the pericardial sac. So heart is something suspended in a fluid filled sac. So what will happen? It will be able to contract and relax. It's not temporary. Temporary is strangulation. Okay. So here is a massive fluid filling. Heart is still able to contract and relax, and it can also move to and fro. So due to this to and fro activity, you will also find a very important finding in the ECG also. So if you are interested to know, let me tell you, it is electrical alternates. You will find alternatively low and high voltage amplitude of this QRS. We call it as electrical alternates, highly suggestive of massive, moderate to massive pericardial. So as you can see here, na, this is in this clip. So when heart is coming closer to the anterior chest wall where the electrodes are placed, so it will look like a it will produce high amplitude. Okay, and when it will move just posteriorly, so lower complex amplitude will be produced. So little bit about pneumopericardium. You can see collection of the air inside the pericardial cavity. So this is the heart. This is the pericardium here. You will see, and also you can see on the right side there is a pleural effusion. Okay, so we have to go very fast. In a coronal plane, it will look like this. Okay, so this is dark structure is hypotensive here, and this is the heart. So you must know about all these things. Little bit pathology, we have to cover a lot of things. So right now it's very difficult. Like, we are going to cover all kind of. This is a pouching from the arch of your tongue. So this is aortic aneurysm. We are going to teach you aortic and contraction of your tongue means narrowing of your tongue. If you see in this clip, you can see here this part. It's a very short clip. This is GIF. You will see in the sagittal plane there is a narrowing, contraction of your tongue. Here I mark the contraction or narrowing. Let us discuss about aortic dissection little bit. You all know that it is acute emergency, there would be tear and which lead to the blood and to the tunica media and form another channel like this. Okay, another channel. So how it will appear in the city? So here one more channel is formed, the aorta. It could be the ascending aorta, descending aorta, arch of aorta. But this is the false lumen because it contains clotted blood. So there is no circulation over it. And this is the true lumen of aorta. It is looking slightly hypertense because this is the contrast study. So we can appreciate that this is the true lumen. Blood is flowing through here, but not through here. This is also emergency. This is descending aorta. So this will dissection. It look like this partition. In the sagittal plane, you will also see this kind of lining. है ना? This is the of aortic dissection. Sorry, I have to go very fast. Let me show you a video very fast. Here you can see. Have you noticed that? Look here. So this is the bright hyperdense structure or bright structure. So this is a true lumen because blood is flowing and there is contrast. So you can differentiate between true lumen and false lumen. And this is a dissection of aorta. And also continuing with ascending aorta and descending aorta both. Okay. Let me show you previously I was not able that was not visible. This is the pulmonary trunk and it's giving left and right pulmonary artery and it is very important section. Especially, can anybody tell me? Yes, Dr. Ajay, you are absolutely right. It's very important pulmonary thromboembolism where we will find a filling defect over here. Grecia, a lot of pathology, but due to lack of timing, I will not be able to cover in this demonstration. So, there are a lot of pathology we cannot cover. So let us switch over to the lung window or HRC. So first of all, you need to know that what is the functional unit of the lung. So this is the functional unit of the hexagonal. We call it a secondary pulmonary nodule. So it contains a bronchiole and always paralleled by a pulmonary artery. And these are the alveoli acinus collection and these are the hexagonal structure. So first, you need to understand this in HRT and because for suppose I have to demonstrate some pathology like let us differentiate how to differentiate between a ground glass opacity. I will be telling you what is ground glass opacity, but right now just understand with this right. So in ground glass opacity, you can see across the uh, opacity. You can see appreciate the vessels. I will demonstrate. Please wait. And in consolidation, you will not be. So ground glass opacity are seen in various factors most commonly in the viral pneumonia or any infectious disease. So later, initially it gets partially filled with fluid, inflammatory fluid or like or with blood. So it is partially filled that we can look across this. When it gets totally solidified, as disease progress, we will see a bright structure or hypertense structure. You cannot see across the ground glass specifically and consolidation. So now let us discuss about the various structures in the HRT. So here you can see these two structures. As I told you here about this slide, that the bronchiole is always parallel by a pulmonary artery. So here you can appreciate whenever there is a bronchiole, you look at this ring-like structure. This is a bronchioles. So these are always parallel by a pulmonary artery. Okay, so we can make out this is pulmonary artery, this is this. And apart from this is pulmonary vein. Okay, because this is not parallel, not there is no bronchiole is seen, and this is also a pulmonary artery, and other structure like septals are there, pulmonary veins are there, and these are the bronchus, locular bronchus. So you must know the normal structure first. Only then you will be able to understand abnormal structure. For example, you must know signatoring sign. Okay, my heart. What happened? There is a dilatation of terminal bronchioles. In this is like and this is from system. So there is a dilatation of terminal bronchioles, and you can see this. Previously, I have shown you. It will always uh, their ratio is same, almost same, and also we can see that less than 1.5, and in older it will, you can find more than a point this 1. So here we can see this is diameter of this bronchiole is just 1.5 times than the pulmonary artery. So it will give the shape of signet ring. We call it a signet shape. So this is the specific feature of bronchic acid and some other disease pattern. And in some disease it could be reversible, and uh, but mostly it is irreversible pattern. Is due to irreversible dilatation of terminal bronchioles. Other, I would like to tell you, interlobular septal technique would be there. You can see here. I have shown you a normal septal. You cannot see here. Sorry, here you can see really any septum. Okay, so here it becomes interlocal septal thickening. It could be due to accumulation of fluid or anything else inflammation, or it could be fibrotic. Okay, so here we can see interlocal septal thickening because they are appreciated very well. Although I have a clip, but there is no sense of doing. You have already you can understand from that previous clip. So this is how it looks in a clip. Other thing is how to next session how to determine whether we are at upper lobe. So just imagine till we are trachea is visible, we are at upper lobes. Okay, till trachea is visible. As soon as we reach at the point of bifurcation of trachea, we can divide the this lung into upper lobe and lower lobe, upper lobe and lower lobe. Very easy in axial section. Although in lateral section, you can very easily appreciate this with the help of the fissures, but in axial plane, you must know how to do it. So as we reach to the cardiac shadow, we have to make a draw a line at anterior, posterior, and anterior 1/3 and posterior 2/3. Divide these two parts. So upper anterior 1/3 will go right middle lobe, and the posterior 2/3 will form the right lower lobe. Similarly, this is the left lingula. That is a depression shape also in that due to the cardiac depression. So this is the lower lobe. So these are superficially about how to. Other thing are various patterns could be there, nodular, reticular nodular, and all these kind of patterns. So we will discuss in the deep. There could be a honeycombing. You can see these are destruction of dilated this terminal bronchiole, giving it the appearance of honeycombing. Now let us discuss about some patterns. Okay, that is more important. If you are able to identify the pattern, you can at least come to some diagnosis or some differential. So first, let us discuss. There could be various patterns: pre-invert opacity, crazy favoring, or round glass opacity, like this. So we will be focusing mainly on these patterns so that it will be useful for you. First, ground glass opacity. As you can see, this is the ground glass, and you can see a braided appearance. It is not completely opaque, but it is translucent. You can still appreciate. So these are seen in the ground glass opacity, as I told you previously. There is some inflammatory. I have told you previously. This is the uh, secondary pulmonary lobule, and you can see this GBO, grayish, ground opacity will appear. I will show you the CT scan picture also, partially filled with fluid. And later, as we go, it will get converted into consolidation. So let us know how it's look in a CT scan. Look here, grayish pattern, this grayish pattern, grayish patches. So these are the ground glass opacity. Look here, more well appreciated large grayish pattern, but you can see across this. Okay, you can see blood vessels beneath this. So you can These are the ground glass opacity. Now, how to differentiate between ground glass opacity and consolidated patch? Because as these provide these consolidated videos get solidified or consolidated. So here is a slide you can with finding. There are GPUs also. These are the great. This is the ground glass opacity. This one all with yellow mark, and this is the consolidated patch. As you can see across the ground glass opacity red present. So this is totally opaque. You cannot see beyond it. Other features are also diagnostic. Let us discuss in this slide how to differentiate between GGOs and consolidation. This is the diffuse GGO page. Previously, I have shown you patches. So this is a diffuse GGO, ground glass certificate. So you can see across the vessels, across the ground glass, you can see the vessel, but not to the consolidated patch. It is got solidified. You cannot see. But you can appreciate some patent bronchioles. You can see here some patent bronchioles there, air filled. So we call it as an air bronchogram sign. So like this in a lobar pneumonia, it will look like a branching like structure, like structure. So it contains air that's why it's looking hypodense or darker. So this is the it is fetal pneumonia or lobar pneumonia. But this is not present in COVID pneumonia, absent feature of COVID pneumonia. Lobar pneumonia is never present. Patchy consolidation is there. So here is a plate. You can just go to it. Let's see large consolidation over here. Sometimes you be able to appreciate some uh, this airborne program kind also. You can appreciate it's moving very fast. You can see and some flies here. Yes, the clear cut demarcation from bronchioles are so in X-ray you can also see in lobar and you can see the debuted the picture will be highlighted and you can easily demarcate the disease part from the healthy part. This is the lobar pneumonia. Similarly, this is the CT, this is the air bronchogram side. You can also appreciate in X-ray if you look very carefully. In some X-ray, you can see the branching pattern like here. So now let us discuss about. I have discussed about GGU, told about GGU. So I also told you that when disease progresses, it will get converted into the consolidated patch. So consolidation will be start from the central part or from the periphery. So similarly, we will call it as endocyne or reverse endocyne. If it start from the center part, so it was previously ground glass activity. Okay. So now it start consolidated, solidified from the center. We will call it halozyme. If it start solidifying for the periphery, we will call it a reverse holozyme or atozyme. I will be demonstrating. Okay. So you can look at this slide. So you can see surrounding there is a grayish pattern in the center. There is a hypertense or dark, right? This is the halozyme. Okay. Organizing pneumonia. So let me demonstrate with a video clip. Just try to demonstrate. I have taken different CT scan clip, and these are the video. And just ignore this. I have just taken this part just to I will use to stamp picture, copy from the picture, and I will put over here. Because CT, you cannot see the progression. You cannot connect. You cannot get everyday CT standard. So how the consolidated ground glass of it will get converted into a hello sign or reverse hello sign is I have tried to demonstrate in this video. So here you can see I have taken this this side, just try to post paste. So just to show you that this is the reverse hollow. So here the consolidation is starting from the periphery. So it looks like atoll ring shape for coral reef island. We called it as atoll sign, reverse hollow sign. Okay. So let us discuss about it with crazy waving pattern. As you can see on the floor, this kind of pattern you might have seen many times in each CT, we can see crazy paving pattern. So what is a crazy paving pattern? There's nothing but just a mixture of, as I told you, interlocular septal thickening. It could be due to correction of the floor edema, okay, and maybe due to fibrosis. So these are the GBO. Suppose if we mix both the features, okay, just mix both the features, so it will look like a crazy paving. How? Let me demonstrate with the help of a video. So here also I have tried to took some pixels and try to paste over here. As you can see, I'm pasting over here, but not looking very much appreciated. But here again, I'm just copying this and placing right here. And just wait. Again, I have taken and just paste over there. You can see here. You can see typical crazy paving pattern. Not that much appreciated because you are looking for a phone and right now. But it's a typical crazy paving pattern. So if you mix this was to demonstrate only. Okay. So these are kind of several videos I have made just for demonstration purpose. So that was little bit about HRCT. Also we have a lot of things. So let us discuss about COVID or coronavirus disease, as you know. So in city, we are mostly concerned with, there was a pandemic, and we have gone through a tough time. So this product classification is published on 25th March 2020 by Netherlands Society. And what does it mean? Actually, product classification raised the suspicions of COVID pneumonia. So there are six type of products, actually one, two, three, four, five, six. In CT, we are mostly only dealing with the one to five because number six is if RT-PCR composite, we will call it directly as for RT6. No need of CT for that. But for CT, if RT-PCR is not available, uh, then we will be making the product creation with the help of the final. So although these are some criteria, Quran 1, 2, 3, 4. So let me tell you, Quran 1, 2 are non-COVID. So Quran 1, just don't look at this chart, not very helpful. It's theoretical chart. Quran 1 and Quran 2 means no COVID. Quran 1 means either CT is perfectly normal, but there could be non-infective pathology, like some tumor could be there, metaphysics could be there, sarcoidosis could be there, non-infective or normal for R1, known causes. Number two, infective but not viral. It could be bacteria or fungal, but not viral. In the for R3, unsure. When a so please don't apply this knowledge mistake. This is, should be reserved for pandemic. Nowadays, COVID is not prevented. You can make mistakes. Okay. So part three means there are some sign of COVID pneumonia, but due to early presentation, uh, signs are not visible properly or well appreciated. So, radiologist or a doctor is neither able to rule out or not able to say with confidence that it's COVID pneumonia. And number four or number five is high. Number four is highly suspicious. Number five is very highly suspicious. So let us go through this and try to understand what it is. Part one, like anything non-infection pathology could be there or normality. Part two, as I told you, you can see here pre and birth appearance. This is the tuberculosis or cavitary lesion. So bacterial infection is there. So this is not COVID, non-COVID. Over part three. So in part 3, there is a radiology will find a ground glass opacity uh, at some place, one or two, occasional. He's just going through and just notice one or two. So it could be due to patient is presenting earlier and is not so he's not able to either rule out or say with confidence this is the COVID pneumonia. So he will make poor art free, like unclear or indeterminate. Maybe in 2 3 days he can develop the changes, but not right. Let me show you a crowd video clip. So here you will see an occasional patch over here. All over the left field is normal. No sign of viral pneumonia. So here you can see one patch of validation and or geomics pattern. So after a few days, this patient presented with the severe COVID. Prad 4 and Prad 5 are almost same. But what happened in let me show you. In Quran 4, you'll find multiple scattered bilateral ground glass opacity. You can see ground glass opacity or converted bilaterally scattered all over the lung field. Okay, there is no predominant pattern in Quran 4, but in Quran 5 there is predominant pattern. There is predominance of this. So if you see multiple ground glass opacity, and then you can call it as a Quran. So Quad 4 and Quad 5 are almost same. What happened in there are multifocal ground glass opacity in Quad 4, as you know. So, but the typical predominance in COVID is peripheral area, posterior, and basal. If this predominance is seen, then we are very highly suspicious of COVID pneumonia. Like, let me show you. Now you can see in this case, they are the contours of opacity predominantly peripherally. You can see peripheral and posterior, peripheral, and as we go down, basal. With this, we will call it at Polaroid. It was just little bit about you need a lot of practice to understand these things, and lot of thing is there. And we are going to teach you broad classification, then how to make CT severity scoring. The patient is need hospitalization or he can be treated at a home isolation if so all these things we are going to teach for each lung lobe. He was scoring of 5 for 525. Okay. So, apart from area of involvement in the particular lobe, you will give percentage of that. If 5% infect can involve score 1, and like this, you calculate scoring 1, 2, 3, 4, and you get the CT severity scoring out of 25. This is how we will be conducting this session, and I hope that you will like to increase your skill and join our program. If somebody has some doubt, then you can ask me. So this was all about today's session. So you can ask some doubt.